Hi, this is Eric Brostowski, and we're having another session of EP on EP. And I'm delighted to have a good friend, a colleague for years, Bruce Lindsay, with me, especially today, Bruce, because I have a case that's driving me a little crazy, and you're such a good clinician, so let me tell you. So welcome to the program, first of all.
Well, thank you, Eric. I'm glad to be here.
Great. So this is a case that's ongoing, and when you hear it, you're going to realize there's no set answer, but I really would like your clinical opinion and get the issue out there. It involves a woman who's in, I think, her mid-30s, if I remember correctly. Anyway, here's her history. She's been known to have a murmur. She's totally asymptomatic. She's 7 months postpartum. She was, I think in her office it was, she's leaning into it. She described a really tall box. She's leaning in there doing something. She gets up quickly. She gets woozy, passes out briefly with a whole bunch of vagal symptoms that were witnessed by people. Okay, that gets her in the system, right? So she sees someone, they notice an irregular pulse. Irregular pulse goes to a cardiologist, right? You've heard this, right? So cardiologist does a Holter monitor and an echo. Okay, so the echo shows mild bileaflet mitral valve prolapse with minimal regurg, mild to minimal regurg. I believe a normal sized left ventricle, if I'm remembering it correctly. Anyway, does a Holter, somewhere like 25 or 26,000 ventricular ectopics with multiple runs, actually of some rapid monomorphic VT with a morphology kind of that posterior papillary muscle area, not exactly sure, but somewhere in that neighborhood. So this is what I see here. Okay, so I'm convinced the syncope, at least from story-wise, sounds vagal. So I'm kind of putting that as an aside at the moment, right or wrong, I'm putting a bit of aside. And I ordered a cardiac MRI. It comes back confirming bileaflet involvement, and a faint, minor, but still there scar in the posterior sort of medial area of her left ventricle. She sees me. I did start her on some beta blockers for whatever reason, hoping it might do something. And she's breastfeeding and she refuses to stop. So I've mentioned things like maybe Sotalol or something. She said no to all that. This is a problem, right? So what I'd like you to do first of all is maybe talk to everyone about this sort of small group of people with prolapse that we worry about, and then maybe we'll bring you back to what you would do. So why don't you start with that?
Yeah, this really does go back a long ways, because when you think about the early descriptions of mitral valve prolapse, I guess going back to Barlow and his descriptions of this, it was recognized eventually that there was some risk of sudden death with it. But it's a classic story in medicine where you have a relatively common problem, probably affects somewhere in the range of 3 to 5% of the population, if not more, depending on how you define mitral valve prolapse. And from what you said, hers wasn't even that severe. And yet, when you look at the percentage of sudden deaths related to mitral valve prolapse is small, probably down in the 2 to 5% range of all sudden deaths. And then if you look at the incidence of sudden death in people who have mitral valve prolapse, that's estimated to be down around 0.2% or so. So it's a classic situation of a common problem, rare catastrophic complications, but what do you do?
Right.
And from your description of that original event where she's reaching in, most of us would have said, well, she stood up abruptly and she dropped her blood pressure a little bit and got lightheaded, and yet you did the testing that we would generally do, especially with an irregular pulse, and we end up finding things we wish we didn't find.
Yeah. Wish we hadn't looked, right?
Well, I wouldn't say that, but you wish it hadn't turned out to be that.
Yeah, exactly.
And so now the question is, how do you risk stratify people for sudden death? And so my understanding of the literature is people have looked at a lot of factors. I don't think the morphology or exactly the runs electrically of what we see are necessarily good predictors of sudden death, but I would share your concern about it. We don't even know for sure that giving beta blockers reduces sudden death in this situation, because you think about what are the effects of beta blockers. Well, they're really designed for different things than this. And then you have people who've looked at the severity of mitral regurgitation. And there's some evidence that people who have biventricular disease have more ventricular arrhythmias than those who have single leaflet disease. And yet that didn't correlate real well with the risk of sudden death. So we don't have great predictors. Now, the other thing that's been looked at is in people who have survived sudden death or who died, when they looked at their MRIs, there was more late gadolinium enhancement down around the base of the papillary muscle. And whether that is related to mechanical impact of the floppy valve on the endocardium or whether there's some other relationship is not certain. So what we're left with is beta blockers may not make a huge difference. I would have concerns about antiarrhythmic drugs like, say, Sotalol. We use it a fair amount, but there's never been a great study showing that this would reduce sudden death, and there are adverse effects of antiarrhythmic drugs. And so how do you know? Mm-hmm. And I suppose you could say, well, if it really suppressed the quantity of these, you would hope that it would be beneficial, but we don't know that for sure. Then we're left with, well, what about ablating the source of it? And sometimes, I've even had people with mitral valve prolapse where it turned out the PVCs were coming from a different area. Now, where you describe it, it's probably coming from the papillary muscle. And sometimes I think depending on how these exit into the endocardium, the morphology can vary a little bit, and yet it probably is coming from that one area. And so you might argue that if you ablated that, you could reduce her risk. But there's always that background concern is, do we really understand the mechanism of sudden death in these patients? And the answer is probably not that well. And do we know that if we ablated these, that she wouldn't come up with some other source of PVCs later? So it keeps coming around to the difficult question of, is this somebody we would put a defibrillator in and program it for long detection times, recognizing that it's not the usual indication for a defibrillator. You originally thought this was a vagal thing, and I think that was a reasonable conclusion, but with this additional information, you have to go back and second guess yourself and say,
maybe not.
Maybe it wasn't. Yeah, and nobody was there recording an electrocardiogram at the time, so you really don't know.
No, and I agree with you there. So, as you might imagine, knowing me, I figured, I know you and I have talked about this before. We've shared stories about patients like this, but I decided to do a delve into the literature because it was a good time to be sure. Yeah. And a lot of what you're saying is there, totally. If you look at the literature, as a general rule, most of them are women, but most, prolapse is more common in women. Yeah. So that's not a discriminator that I could find for people who had cardiac arrest or that sort of, or pathology series. Bileaflet was most, but again, you're right. It wasn't 100%, but most of them were bileaflet. Mm-hmm. So let's chalk that up as a risk factor.
And generally more severe, I think, than you've described.
Yeah, and that's the older literature. There's no question. Yeah. If you take a look at the older pathology literature, there are big billowing valves. But in more recent literature, that's not always held up. There's a series from the Mayo Clinic. There's a series from Italy. But I 100% agree. I used to teach that they had to be very redundant big valves, okay? Because that's what the pathology literature suggested years ago. To my dismay, I found when I started looking at some of the more recent papers that that's not always the case. So again, I'm just using your point. So we can't say that's a discriminator necessarily, except more commonly bileaflet, like you said, yep. More commonly women, but women are more common, yep. Runs of VT in a couple series suggested yes, and multiform PVCs, yes. Again, just like you said, there's no one like aha moment. Yeah. It's a constellation. And then I looked at a paper on ablation from the Mayo Clinic that they had looked at these, and these were not people necessarily who had cardiac arrest, but they did have some ICDs in them for other reasons. It's interesting, at least in that one paper, they still had therapies, even though they got rid of the PVCs, which speaks to your point, but therapies were less. But they weren't zero when they got rid of them. And so, yet they did another series, but they were symptomatic patients. And they also mentioned, which concerns me a little bit about the ablation, to your point, that they actually accelerated some of these, and within the next day, some of them had like rapid runs they didn't have before. So I don't know that you can't make it proarrhythmic. So now you see my conundrum. So after going through the literature, to add to what you've very nicely gone through, we're back to, what do I do?
Well, and if I remember correctly, the Mayo Clinic publication looking at the relationship between biventricular or bivalve versus single valve disease, somewhat paradoxically, the people who had VT were more associated with the bileaflet disease, but sudden death wasn't.
Yeah, I don't remember that
Yeah,
differential. You may
yeah.
be right, but certainly the VT was bileaflet.
Yeah, it was, but
Yeah.
the whole issue of sudden death isn't. Plus, the problem we've always had with ablation of ventricular arrhythmias is, no matter how good the site is, there's a certain recurrence rate.
Correct.
So if your rationale is, okay, if we ablate this, we don't have to put a defibrillator in.
Right.
Well, what do you do when it comes back?
Yeah, no, I agree.
And so, I mean, you can monitor these people extensively. Is this somebody you'd want to put a loop recorder in and say, well, if she has another syncopal episode, we'll know why? Well,
Unless it's
the problem
sudden
there
death.
is she might not survive.
Exactly.
And so
It's
you
a
have
bad moment.
You have a young woman who, I mean, we don't want to lose any patients, but there is no question there is a greater burden in this decision when it's a young person
Yes.
with a young child.
Yes.
And so I probably would consider an ablation procedure to reduce the burden. There's a secondary issue of, well, if you have that many PVCs, might it affect the ventricular function eventually?
Right.
She's in that range, but oddly enough, some people with a lot of PVCs, it never does affect their ventricular function. And you can't really look at the morphology that accurately to predict that. So you could just follow her in that sense. But you could argue that if you could reduce the PVCs, you could reduce the risk of a change in her ventricular function. But that really probably isn't such a strong argument, because you could get serial echoes if that's all you're worried about. The real issue is, could you reduce the risk of a sustained ventricular arrhythmia? And then the difficult decision is, do you put an ICD in as backup? And I think a subcutaneous ICD would have relatively low risk for her. And their sensing has gotten better. You can program them for long detections. And so I think that certainly would be something where you'd sit down and discuss it with the family, discuss it with the patient, the uncertainties that everybody has, and try to reach a conclusion that is consistent with what she would want to do.
Yeah, I think those are great words of wisdom, Bruce. She's one of these people that have literally kept me up at nights. I mean, I mean, a couple times I've sort of just awakened with this kind of thought, like, what
do
am
you
I
do?
do? Yeah, why am I messing around here? Because I started looking at statistically. I started thinking to myself, I've been in this business close to 39 years now. Okay, I've seen tons of people like you have, who have prolapse, who have arrhythmias. I only have a few patients like this. She's like 3 standard deviations away, like you nicely said. Here's how common prolapse is. In the prolapse group, here's the tiny little bit to come like this. And my thinking right now, although there's no guideline to, there's nothing to guide us, is to put a subcutaneous ICD in. They last a lot of years. Let's maybe yes, maybe no, do an ablation then. Maybe just watch her like you suggested. I'm sort of leaning that way, but I haven't made a final decision.
Yeah, I think that most people would share all the concerns that you've raised and go through the same process. It is one of the more difficult things we deal with in medicine, but it really comes down to, if ever there's a time for a shared decision, not a term I necessarily like. I think it's one of those sort of things in vogue. But nonetheless, it's something we've been doing for years, no matter what we called it.
Exactly, that's my point.
And it is a shared decision, because
definitely
it's one of
shared,
those things where they're looking for you for guidance, but nonetheless, what you would recommend to them or what you would do depends partly on what their concerns are. If she said, no way would I ever want to have a defibrillator and I'd rather die, well, then you're not going to put one in. But if what she's really afraid about is she's not going to live to watch her child grow up, then I think you have to look back at that syncopal episode, which does, by description, that alone, most of the time is nothing.
Right.
But in this patient, maybe it was real.
I think you're right. And the shared decision, and you and I share, are not like, and I'm sure the people listening to this, we're going to probably both get 1,000 calls. But it's not because we don't agree in shared decision making, it's just putting a term on something that
Right.
you and I have done our whole careers.
Right.
I will tell you though, I started off by just telling her I'd like to try a beta blocker, and she rebelled. I mean, just the fact that she'd had to take any drug. And then I very carefully mentioned an antiarrhythmic, and she said no, out of hand. And then on the second visit back, I started the discussion of the ablation, telling her fully, honestly, our discussion that I don't know that is the best thing for you. Would you at least consider it? So she's not ready to do it. She's considering it. I got to be dead on honest with you. I didn't even want to go with the defibrillator initially because of all the things.
Right.
If I tell her, listen, I'm thinking of putting a defibrillator in you, it's like, oh my gosh.
I think it's a discussion that you have to have eventually.
I think
because
that's my next discussion.
I spend most of my days doing ablation procedures, but we have to recognize the limitations, not only eliminating those PVCs, not only the risks of doing the procedure, which are manageable, but the uncertainty whether even if we did that successfully, have we completely eliminated the possibility they could recur,
Right.
or is there something different about these
Yeah.
people? And she does have some scarring by the MRI, or at least
Yes,
suggested
some.
by that.
Yeah.
It's not necessarily at the base of the papillary muscle, but it's also possible that I've seen some descriptions in the literature where the scarring isn't always at the base of the papillary muscle.
Right.
And it may have to do with a whole development of the mitral valve annulus, and that there's something about that.
All you're saying is true. So the purpose for me presenting a case like this to a senior clinician like Dr. Lindsay is to get all these things out of there. I've presented cases like this to trainees and they never even heard of it. So if nothing else, I'm still not sure where I'm going, as far as my final decision, but I'm going to have that ICD discussion at least. I just think people need to know about this very, very uncommon but important variety of
But
prolapse.
it's interesting that you've raised that, because when I was training, I think that was a pretty well-known risk. I think what's gone on over time is there was a period of phase where mitral valve prolapse seemed to be related to everything. And I think people began to dismiss it a bit. But there clearly is this group of patients that are different than the usual patients. And most of them have myxomatous degeneration. That's the most common cause of this. But there's something different about these subsets of patients. And maybe people have forgotten, since it's not a very specific marker, maybe they've kind of forgotten that, yes, there is that small group out there that can have a cardiac arrest, and it adds to the dilemma of what to do for them.
Well, Bruce, great discussion as always. Thanks for joining us today. Thank you.
Thank you, Eric.